Welcome to the final week of Season 1 of the Leukopak Lady. Today I'm shifting away from leukopaks just a little bit, but staying in the CSM space by diving into a big question in cell therapy manufacturing. Which tissue source is better for producing mesenchymal stromal cells? Bone marrow, umbilical cord tissue, or adipose tissue? Spoiler alert, there is no one-size-fits-all answer here. The best source really depends on your therapy's design, the patients or donors you're working with, and your regulatory and manufacturing strategy. So let's break it down. First up, bone marrow-derived MSCs. These are the original, most defined, and clinically validated MSCs. We know a lot about them, and they've shown strong immunomodulatory effects and tissue repair potential. This is why they're often favored when immune modulation or autologous use is critical. But there's a catch. Bone marrow aspiration is invasive, and it usually yields relatively low numbers of MSC precursor cells. Plus, donor age matters. Older donors often mean slower cell growth and weaker function. So while bone marrow MSCs bring strong clinical precedent, they also bring some practical challenges. Next, umbilical cord tissue-derived MSCs. These come from birth tissues that would otherwise be discarded, so they're non-invasive and ethically favorable. They have a really high proliferative capacity, making them well-suited for allogeneic off-the-shelf therapies. On the flip side, they don't have as long of a clinical track record as bone marrow MSCs. And processing variabilities, like how the cord tissue is handled, digested, and the cells expanded, can introduce manufacturing inconsistencies. And these inconsistencies can affect clinical outcomes. So you get scalability, but you also inherit some standardization challenges. And finally, adipose tissue-derived MSCs. These come from liposuction procedures, which are minimally invasive compared to bone marrow aspiration. The big advantage, you get large numbers of MSC precursors right from the start, and they expand robustly in culture. In fact, adipose MSCs often match or even exceed bone marrow MSCs in their immunomodulatory functions. But, and this is important, donor factors like age, metabolic health, and obesity can strongly affect quality, and this can affect patient outcomes. From a regulatory standpoint, adipose MSCs still face more limited precedents than bone marrow or umbilical sources. So which is best? Bone marrow if you want strong clinical precedent, especially for autologous or immune-focused therapies. Umbilical cord tissue if you're building an allogeneic, scalable, off-the-shelf therapy. And adipose tissue if you need high yield with minimally invasive collection. But you have to carefully manage donor variability and regulatory pathways here. So the bottom line, the best source is contextual. It depends on your therapeutic goal, donor considerations, and the regulatory environment that you're operating in. So thanks for joining me today. Come back for the next episode to check out my breakdown on whether T cells or NK cells make the best CAR therapy. Or maybe it's gamma delta cells.